You've seen my disclosures previously. About 15 years ago, I was invited to undertake research at St Mary's Hospital in this special MRI scanner. And the unusual thing about this particular machine is that there are two vertical coils that you can see, rather than a single coil. And this was designed to allow a patient to be put into the MRI and actually have surgery during the scan. And you could have an operator and assistant, and they could do their laparoscopic surgery, and then you could use the MRI to look inside an organ, for example, a liver or other viscous. But I took out the stretcher and we could stand a person up, and that for the first time we could image the human knee in a living situation, weight bearing. And you can see a device attached to the leg, and this meant that despite movements of the joint, we get the same plane of scanning. So effectively, we would take one slice of the knee and follow it throughout the whole range of knee motion. We did this many, many times, but probably our best publication is in the Journal of Biomechanics, reporting on 10 males. And as I say, we're very confident the results was reported many times, and we stood them up and then made them have to squat in 10-degree increments. And at each 10 degrees, we got a new scan in the mid-medial and mid-lateral in a sagittal section. And we use this tracking device to make sure we have the same slice all the way through. And on each individual scan, we had two observers measuring them, and we got a reference point on the back of the femur by applying a circle, and the center of that circle was the reference for the femur. And we measure the distance from that reference point to the back of the tibia. And if that changed between angles of flexion, it must indicate a relative motion of the femur on the tibia. So these are the average results for the lateral compartment. On the x-axis, on the left, minus 10 degrees hyperextension, and on the right-hand side, 140 degrees deep squat. The y-axis is the millimeters from that reference point on the femur to the back of the tibia. So as you can see, on the left-hand side of the graph, the femoral condyle starts, and as the knee flexes, the lateral femoral condyle moves posteriorly. Initially quite quickly, then it slows up for a long period, then at 120 degrees it jerks back quite quickly. So if you like, on the lateral side of the knee there is rollback. And we put this individual scans together as a cine loop, and you get the feeling of a really dramatic movement in the lateral compartment. In deep flexion, you'll see that the femur is almost subluxed off the back of the tibia. And you can see the anterior and posterior horns of the meniscus move with the femur. An unbelievably mobile part of the knee. On the medial side of a joint, the results were very different. And you can see that with the axes the same, the average of those 10 knees, from the left-hand side in full extension, there's very little anteroposterior motion of the femoral condyle, all the way up to about 120 degrees. And then at 120 degrees, there is something that changes. Now that's quite an important position in knee motion, because active flexion using hamstrings goes as far as about 120 degrees. And the last 20 degrees are purely passive. And so in the active range, the femur is not really moving. So that is not what most of us understand by rollback. And here's the medial side of the joint, and for the most part of the range, the femur is bang smack in the middle of the tibia. It doesn't move back with flexion until the last few degrees. So very stable arrangement, very different from the lateral side. And if you put together that differential medial lateral motion, you see that on the medial side of the joint, up until 120 degrees, there's very little motion, whereas laterally there's a steady progressive motion. If you like, on the lateral side there is rollback. But what we have is axial rotation of internal tibial rotation or external femoral rotation as the knee flexes. So having looked at normal kinematics, we wanted to see the effect of ACL and PCL deficiency, and we found 5 patients who had isolated ACL or isolated PCL deficient knees, no collateral ligament damage, no meniscal damage, normal chondral surface. We put them in the scanner, and guess what? Their normal knees looked like our previous studies. So these schematic diagrams are the imaginary lines connecting the medial and lateral femoral condyle reference points in extension up to 90 degrees. And we put the deficient knees in, and we found that the patterns were interesting. On the ACL situation, the abnormality was in the lateral compartment. There was no change medially, whereas in the PCL deficient knee, the kinematics changed medially. And so there are a lot of implications from that, but this conclusion for the ACL, which is what we're talking about today, is that effectively ACL deficiency gives you lateral alteration of kinematics. So every patient has a unique pivot shift, and that's represented by this diagram. And the pivot shift combines anterior tibial translation with internal rotation, and that relative amount of those two components is different for every single patient. It's different for every single examiner, depending on how much force and how they apply that force to the knee. So the question is, how do we deal with those abnormalities? So in the 70s, ACL surgery was developing, and by the 80s, techniques became more reliable. You can see in the bottom X-ray, very abnormal position of the tibial tunnel in particular, and it became an obsession to avoid anterior tibial tunnel placement, because if you put a tunnel there, the graft is going to impinge on the intercondylar roof with a knee extension. And so as the technique became refined, and particularly as the Americans drove it, they told us that we must put our tibial tunnel posteriorly. And this MRI scan comes from a description of how to best do ACL reconstruction in the mid-90s from a very famous surgeon who you will all know, but I won't mention his name. And he said that this is an ideal position for the tibial tunnel. But you can see it's pretty posterior, and as a result, the graft is relatively vertical, and it's less able to do its job. Furthermore, if you have a posterior tibial tunnel, as the knee flexes, the PCL tightens, and the two ligaments will impinge, and people often lose 10 degrees of flexion, which can be problematic. So that's the tibial tunnel. And I was taught in the mid-90s in Australia that you can't put the tibial tunnel too posteriorly unless you take out the PCL. Well, I would suggest that's wrong. Then on the femoral side, there was an obsession with isometry. And this device comes out of a manual from the AccuFX guide in the early 90s. And you put this little tack onto the bone and use a suture and measure isometry throughout the range. And the idea was that it was imperative to have an ACL graft that was isometric throughout range. And if you look at these 3 points, A, B, and C, with today's surgery, you might choose C, you might choose B. You wouldn't choose A. It's not even in the footprint of the ACL. But guess what? In 1994, when this manual was prepared, this was the ideal position. And so I've shown you on the sagittal image with a posterior tibial tunnel, a relatively vertical graft, and with the ideal position in the mid-90s being high, right at the back of the notch, a relatively vertical graft in the coronal plane. And if you want to control rotation, a vertical graft is not what you want. So again, the company's got good at making this operation user-friendly, and transtibial drilling became the norm. If you put in an angled guide like this at 40 degrees, with the guide, top of the guide parallel to the joint surface, as you drill, you would hit what was thought to be the best position on the femur. And the problem is the tibial tunnel determines where you place your femoral tunnel. And so as a result of transtibial drilling, people would often have a truly non-anatomical position on the femur. And I'm revising a case later on this morning, a live surgery, and exactly that's been done. So let's go back to the anatomy, which is not a bad place to start. If you look at the ACL in this specimen, I'm grateful to Charlie Brown for these pictures, people describe the ACLs in 2 bundles. There aren't 2 bundles in terms of anatomy. There are 2 functional bundles, and I accept that. So in extension and inflection, the anteromedial bundle, A and B here, is relatively isometric. But the posterolateral bundle, which is tight in extension, becomes slack in flexion. And with that understanding, it led to the double bundle principle. The French group, this picture is from Philippe Colombe. You can see the 2 different bundles. The green one is the anteromedial. It's good at resisting anterior tibial translation. And the idea was that adding a posterolateral bundle, the blue one, would control rotation. because of the problems associated with double bundle techniques, double bundle ACL surgery is getting less popular. And so it was a natural progression to say, rather than having two individual bundles, let's have one central bundle within the tibia and within the femur. Again, courtesy to Charlie Brown, I've got these pictures, and you can see in red the AM bundle position and in green the PL bundle position. Now, the guys who were double bundlers who moved onto the central femoral footprint had the arrogance to call themselves anatomic surgeons. If you put your graft anywhere in the footprint, surely it's still anatomic, I would argue. But when people refer to anatomic, they mean a central position in the femur. I think most people would agree that a central tibial position is sensible and it works. But the question is, which is best on the femoral side? So for a long time, I was an AM bundle person, but eventually I was convinced by my friends, particularly the guys with the ruler, that I should go for a central position on the femur. They've also concentrated on the anatomical landmarks within the notch, and it's useful to think of the knee not in the anatomical position, but in the 90-degree flexed arthroscopic position. And if the soft tissue is cleared off the lateral femoral condyle, as you can see here, particularly if you view it via an AM portal rather than the usual anterolateral portal, you can appreciate these the bony landmarks. The top line is the intercondylar line or residence ridge. Everything below that line is the ACL footprint. Everything above it on this picture is non-anatomic. And then the more vertical line is the so-called bifurcate line that divides the footprints of those two functional bundles. And so if you're a double bundle person, you would put your two drill holes here. So that PL bundle, the one in the foreground, is unbelievably close to you compared with the traditional positioning of femoral tunnel. So here is an AM bundle, which corresponds to the cadaveric specimen on the top right. And here is the so-called anatomic or central footprint position. Now what's depressing is after 30 years of talking about tunnel position, these are not close. And if you look at the AM bundle relative to the central bundle, there's probably around 8 millimeters difference. So it's amazing that we've gone from a technique that was working, you'd think we might move a couple millimeters, but because of the double bundle people, then the central bundle people, we've moved a long way. And I looked at my results last year for the ISICOS meeting, and you need to listen to this, in my elite footballers, and they're a patient group who actually use their ACLs. Many people don't use their ACLs, as you know. In that group, I doubled my re-rupture rate by moving from this position, the AM position, to a central position. Now, if you deal with your average patient, they often don't use their ACL, and you can do anything. Even allograft works in those patients. But in professional sports, they will use and they will test your ligaments. So you can pick up weaknesses and differences. And I doubled my re-rupture rate. And so I've gone back to where I was 10, 15 years ago. And there are two ways of looking at it. Perhaps the guys who have the central footprint, the Freddie Foos of this world, have to accept a higher re-rupture rate because they'll say that their ligament actually has to work, it's under more tension, and some of them will fail. But if it doesn't fail, those knees have the best kinematics, they have less risk of osteoarthritis long term. Or you could say they've got it wrong. And maybe that's the case because there is some evidence now that whilst it's understandable to think that the center of an ACL is where all the action is, there is some evidence from these people here, Andre Amos, the Japanese group who worked at Imperial College where I do my research, Andy Prell at HSS New York, and Rob Smigelski. Maybe the bit of the ACL that does the work is where this white dot is, not the middle of the ACL. And so that's food for thought. Just finally talking about grafts, there's a lot of historical legend, if you like. And I wanted to hear this fact. 4-strand hamstrings are stronger than patella tendon. And it made me feel good because I'd learned how to do hamstrings in Australia, and I was a really strong advocate of hamstring tendon. But it makes no consideration at all for the fixation strength. And patella tendon has got to provide the best fixation. It also is reliant on time zero testing in the lab. What happens after you've placed your graft? Well, what happens is the graft goes soft. We rely on biology to heal it. We don't even understand that process. And so the patellar tendon, I would say to you, actually is, and always has been, the best graft. But maybe the price of harvesting it is a bit bigger. But even that is improved hugely. And I would say to you, if it wasn't for double bundle reconstruction, patellar tendon ACL reconstruction would become more and more popular once again. Thank you.